All right, so we'll go ahead and get started for another one of the AMSSM ultrasound case presentation series. So once again, just wanted to give a quick plug and quick reminder about the AMSSM Library of Sports Ultrasound Pathology. So this is a really good way to take the pathology that you see in clinic, the training room, or the sidelines and actually turn this into a publication. So the AMSSM Sports Ultrasound Committee is still looking for both common and unusual pathology related to sports ultrasound. So this is a really good way for trainees and staff to add to the growing series of the Library of Sports Ultrasound Pathology, as well as actually get a peer-reviewed reference for your CV. So if you're looking into this opportunity, it can be found under the AMSSM webpage. Also, you can always email Josh Romero as well, too. Otherwise, then today gonna get started by introducing our speakers. So we have two speakers coming from the UPMC Sports Medicine PM&R Fellowship today. First is going to be Sharnée Mead. She's originally from Columbiaville, Michigan, and trained at the Michigan State College of Osteopathic Medicine for medical school, and then attended Case Western Metro Health for PM&R residency. And as mentioned, she's now at the Pittsburgh Medical Center for her PM&R Sports Medicine Fellowship, and is currently also serving as a physician for the USA Weightlifting and International Masters Weightlifting Association. So her primary clinical interests are diagnostic ultrasound, as well as advanced ultrasound procedures and caring for the strength athlete. And soon she's going to be starting a sports and musculoskeletal practice at McLaren Northern, which is in Petoskey, Michigan. And then our second speaker is going to be Dr. Eric Super. He graduated medical school from the Uniformed Services University and residency from the National Capital Consortium Physical Medicine and Rehabilitation Residency. He's currently completing his PM&R Sports Medicine Fellowship, as mentioned, at the University of Pittsburgh Medical Center. And he is a captain in the United States Army. And after fellowship, he'll be heading to Fort Liberty, North Carolina, to serve as the brigade surgeon for the 18th Field Artillery. And today they're both going to be then presenting on a mid-quadriceps strain.
Thank you, Steve, for the introduction. So we'll go ahead and jump in. We're going to be talking about a quadriceps strain today. So our objectives today is we're going to discuss anterior thigh pain in a football player. We're going to review some anatomy of the anterior thigh and talk a little bit about clinical correlates before we jump into a complete diagnostic ultrasound protocol for the anterior thigh and hip. Then we'll talk about some images from our case, and then we'll review our ultrasound report after the diagnostic scan. Before we jump into the case, we just want to give thanks to our program director, Dr. Ryan Nussbaum, for his assistance preparing this case, as well as his mentorship over the year. Without him, we wouldn't have been able to put this talk together today. So jumping into our case was a 21-year-old male football kicker who had had about 2 months of anterior hip and thigh pain. His pain started during his conditioning in training camp about 2 months ago, and he was able to push through the pain for about 2 weeks before he ended up seeing the athletic trainer. And with his athletic trainer, he was able to work through some rehab, but he had inconsistent good and bad days, despite having some periods of rest built in there as well. Before he came to see us, he was able to return to punting, but he was unable to really return to field goals and kickoffs. And he denied any discrete pop, bruising, or tissue deformity that he ever noted in his thigh when this pain started. He told us that at this time, his pain was most exacerbated by the hip and knee extension in the backswing through foot contact of his kick. And his past medical and past surgical history was only notable for a history of a right hip labral repair and an operation for cam morphology about 4 years ago, which he had since returned and played multiple seasons of football without any issue. So on physical exam for our athlete, he had no visible deformity or ecchymosis. He had full symmetric range of motion in both his hip and knee. He had 5 out of 5 strength in his lower extremities. Was notable that he had palpation or pain with palpation in the proximal middle aspect of his anterior thigh with reproduction of his symptoms, as well as symptoms were reproduced with resisted straight leg raise, testing hip flexion with his knee flex, as well as with knee extension. His gait was normal and he was able to squat without any pain. However, when we had him attempt a single leg squat, his pain was reproduced as well. And he had negative single leg hop test, negative log roll, scour, fader, and favor. So for our approach for planning our diagnostic exam for this patient, we wanted to look at both the anterior thigh and the hip. For the anterior thigh, the important muscles to cover is the rec fem and the vastus medialis, lateralis, intermedius, and then including the sartorius as well and on that. For the anterior hip, we included the femoral neck, because of this patient's history of a labral repair and cam osteoplasty, we wanted to also scan the anterior hip. So we included the femoral head and neck, acetabulum, anterior labrum, iliopsoas, again, the sartorius, rec fem. We also added the TFL and then looking at the femoral nerve, artery, and vein to make it a complete scan. These protocols we developed as a combination of the AIUM's practice parameter for performance of an MSK ultrasound, as well as the AMSSM sports ultrasound curriculum recommended structures for fellows. And so combining those two practice guidelines, we were able to kind of form our structure list. So for optimizing our assessment of this patient, the positioning for the anterior thigh and hip is primarily supine with the hip neutral flexion and rotation, with some dynamic flexion and rotation of the hip as needed in assessment, which we'll talk about a little bit more when we're getting into our scans about any position changes that we use. As far as transducer selection, we utilize both a high frequency linear and a curvilinear transducer, depending on trying to optimize our image resolution. And for deeper structures, we needed the curvilinear to really be able to characterize those better. So just to review some anatomy before we jump into our ultrasound, it's important to highlight some of the unique anatomic features of these muscles. And so these images are from an article by Pasta et al. About sonography of the quadriceps muscle, with citation down there at the bottom. But the most superficial part of the quadriceps is going to be the rectus femoris muscle, which has both an indirect and direct head, which we'll talk about more on the next slide. And then deep to that are the three other muscles of the quadriceps. So you're going to have the vastus lateralis, intermedius, and medialis. And it's important to note with the vastus lateralis and medialis, they both arise off the trochanteric line and the linea aspera, but off the medial and lateral sides respectively. And the vastus lateralis is going to start as a thicker muscle, and then that cross-sectional area is going to taper down as you scan distally down the thigh. The vastus medialis has the opposite morphology. And so it starts narrower and then becomes larger as you scan down distally. And the vastus intermedius really arises from that whole anterior lateral portion of the femur. And as you're scanning through the thigh, it's going to be that muscle belly that hugs is deeper to the other three and hugs the aspect of the femur. And vastus lateralis, intermedius, and medialis are most commonly injured in direct trauma versus rectus femoris. We more commonly see injury in indirect trauma. And then jumping into a little bit more rectus femoris anatomy, there are already AMSSM cases on this topic, but just want to talk about some things that are relevant for our talk. One of those talks is Dr. Bailowitz covered the anatomy of the rectus femoris in his video, and then Dr. Bacall and Davis also covered a video on looking more at the direct and indirect tendons and the origin of the rec fem. So I highly recommend those videos for anyone that wants to learn more about the rectus femoris anatomy as well and ultrasounding that. But for the purposes of our talk, we just wanted to highlight the features of rec fem in this image on the right, which is from this article by Hasselman et al. And the important notes is that rectus femoris has kind of three unique aponeurotic expansions that are described, with the direct tendon coming off of anterior inferior iliac spine, indicated by the striped portion of this image on the right, becomes the superficial aponeurosis as it travels distally, while the indirect tendon is the white portion here, which comes off of the supraacetabular ridge, then becomes the central tendon of the muscle as it travels down distally. And then the rec fem goes from this kind of bipinnate structure, proximally with two separate tendons, down into unipinnate as it's inserting, and that is the posterior fascia that's indicated down here by the white at the bottom of the rec fem. And while direct tendon, indirect tendon injuries typically have a more acute, like an insidious or acute onset where the athlete can recall that there was a pop, there was this event. Central tendon injuries are more commonly, there's no acute injury, no discrete pop or any specific finding that the patient recall from that. So before we try to look at these individual muscles, it's good to have a home base view with scanning any part of the body. And this is our home base view for the anterior thigh. And so for this view, we're scanning lateral to medial and short axis across the mid femur. And as we're scanning across, there we go. So we have vastus intermedius is going to be down here deep. Vastus lateralis is that first superficial, rec fem coming in, and then vastus medialis on the medial aspect. Let's play that again, just because there. So vastus lateralis, intermedius down here at the bottom, hugging the femur, rectus femoris at the top, and then vastus medialis most medial. So with this home-based view, we can then track those muscles proximally and distally, and then we can really look at the origin, the insertion, or if we have clinical concern for an injury to them, looking more in the region that the patient's symptoms are in. So now talking about the rectus femoris muscle and its tendons on this patient's ultrasound examination. So first looking at the direct tendon, which comes off that anterior inferior iliac spine that we mentioned. Here we have it in short axis, and it's indicated by the blue arrows. And then we looked at it in long axis as well, and we noted that the direct head of the rectus femoris looked normal with no significant thickening or cortical irregularity, and it appeared normal fibrillar echo texture throughout this scan. And then we also looked at the indirect tendon, which, like I mentioned, Dr. Davis and Dr. Pakal had a where they go into more detail about illustrating the structure. And for this, we also commented that the indirect tendon looked normal with no significant cortical irregularity or thickening noted as well. So then as we scan the indirect tendon distally, it starts out on the more medial aspect like we showed in that image before, indicated here by the blue arrow. And then as we scan further distally, it becomes that central tendon. And we have the superficial aponeurosis here superficially, and central tendon there in the middle of the muscle belly of the rectus femoris. And so we saw a little bit of pathology there, which we're going to show in a little more detail here with a clip. And so now we're scanning distally to proximally. So we have the central tendon here, and there's an anechoic lesion deep to the central tendon, which extends proximally. So then we want to characterize this lesion better, so we include some additional views. And so we include looking at this lesion long axis sliding from lateral to medial. We now can see the longitudinal extent of the lesion. And we can see the central tendon there as well. And then it was important to measure this lesion. Measurements of intramuscular lesions can help prognosticate return to sport for athletes, as well as give you some idea about whether it's progressing or whether it's improving if you see this athlete serially. So for us, we measured it longitudinally in long axis at 5.3 centimeters. In short axis, we measured it at 3.29 centimeters. And then because of this anechoic appearance, we wanted to make sure that it wasn't vascular. So we also looked at it with Doppler, and we saw no vascular flow. And then we also checked it for compressibility, and we found that it wasn't compressible as well. And so for our report for this, we described it as an anechoic avascular lesion, which is identified intramuscularly, and the measurements there. This anechoic lesion does appear to partially involve the posterior portion of the central tendon. And with dynamic assessment, we did demonstrate that most of the central tendon is intact. And there was pain with reproduction of the patient's symptoms with sonopalpation of the lesion as well. So now we're going to move on to the rest of our scan, and I'm going to pass it over to Dr. Mead.
All right, so now we'll cover the vastus medialis, lateralis, and intermedius, starting with the vastus medialis here. To begin our evaluation, we'll be looking at it in short axis here, just distal to the myotendinous junction. And it's, as we see from the still image on the right, our vastus medialis is going to be medial and superficial to the vastus intermedius and medial and deep to the rectus femoris as we were scanning. And as we scan this more distally, the transducer will move more medial relative to the origin of the muscle. At the distal aspect of this muscle, we'll see the vastus medialis blend into the quadriceps tendon to make up the intermediate and medial aspect of the quad tendon and the medial retinaculum of the patella. This distal attachment allows for the vastus medialis to apply a median axis of force, thus acting as a medial patellar stabilizer. So this is our live scan. So we'll go from proximal and lateral to infromedial as we're scanning through this structure. And as we see, it's ballooning here. And as we come down distally, the fibers do change as they become the vastus medialis obliquus portion of the muscle before it blends into the patellar retinaculum here. The delineation of these fibers varies from person to person and it's not well described. However, this is a feature that you can look at in more detail if you want to follow the fibers in long axis here. The vastus lateralis is the largest of the quadriceps group, and it originates from the superior portion of the intertrochanteric line and the anterior portion of the greater troch, the gluteal tuberosity, and the lateral lip of the linear aspera. In our orientation on the left, we'll see that we're looking at this in short axis again, and lateral to the rectus femoris at the proximal aspect of the muscle. it terminates in the lateral portion of the quadriceps femoris and the lateral retinaculum of the patella. And so as we move down more inferiorly, we see that this vastus lateralis is superficial to the intermedius. And as we see from the orientation here, distally, the vastus lateralis will blend into the middle portion of the quadriceps tendon, and it's going to be superficial to the intermedius even as we get distal into the thigh. So in this live scan of the vastus lateralis, we'll see the muscle just after its origination off the femur, and as we move the probe inferior medial, we'll see the path it takes to coalesce into the quadriceps tendon and the lateral retinaculum of the patella. So we'll play it here. And it is rising right here. And we will move medially as it blends into the quadriceps tendon. So the vastus intermedius is the deepest of the 4 quadriceps muscles. It originates off the anterior and lateral surface of the femur and it inserts deep on the deep portion of the quadriceps tendon. The orientation here is labeled on the right. And we're in short axis in this image as well. And as you can see, the vastus intermedius is the deepest of the 4 muscles, and it has a short tendon coming off of the femur here more proximally. And distally, it does blend into the deepest portion of the quadriceps tendon as it inserts onto the patella here. So our figure on the left, again, is demonstrating the pathway that our probe will take as we're scanning this in short axis. And we can appreciate as we scan here, the typical muscular ecotexture of the vastus intermedius arising deep to the vastus lateralis and the rectus femoris, and how it was circumferential around the femur as we scan here. So our overall interpretation of our vastus muscles is that they appear to have typical muscular and tendinous ecotexture throughout the entirety of this evaluation. Usually when a patient presents with anterior thigh pain, the quadriceps is usually the assumed injury, but rarely we can have myotendinous injury of the Sartorius or TFL that can implicate our anterior thigh pain. So we did include that in our evaluation as well. And we'll start with the Sartorius here. So to begin evaluating the Sartorius, we can easily orient ourselves to it by scanning in short axis medially off the anterior superior iliac spine. And we can see that probe placement here on the left here. And as on the right, we can see the Sartorius has a fibrillar pattern as it comes and attaches onto the ASIS. We don't note any cortical irregularity here in this image. So in this live scan, we'll follow the Sartorius into the mid-thigh, generally into the area that our patient had discomfort. And as we get into the mid-thigh, we see the Sartorius traversing over the adductor canal, also known as the subsartorial canal, which houses the femoral artery and vein as well as saphenous nerve. It's important to note that this muscle also attaches to the pes anserine onto the proximal and medial aspect of the tibia, but is outside of the scope of this talk today, so we'll only follow it into the mid-thigh. So here we see our Sartorius starting more laterally, and as we scan more medially, it comes over top of the adductor canal there. And this image depicts our evaluation of its attachment onto the ASIS and long axis, and we can appreciate the myotendinous junction here, and it appears to be intact and lack of cortical irregularity at the attachment of the bone. So our overall interpretation of this is that our Sartorius appears normal at its myotendinous junction and its attachment to the ASIS. Now moving on to the tensor fascia lata. It originates at the posterior lateral aspect of the ilium and can be easily found by scanning laterally to the ASIS. So usually when we do these scans, we'll evaluate the Sartorius more medially and then the TFL more laterally after the ASIS. So this will insert distally onto the iliotibial band, which will then go on to attach to the proximal tibia and to the Gerdy's tubercle. Again, our left image is our orientation, and we're looking at this at short axis at the proximal origin. So here we see the TFL just becoming a muscle belly, just superficial to the vastus lateralis. And then the left shows our pathway of our probe as we scan more distally. The lateral aspect of the ASIS is going to be off to the edge of our screen as we scan, and we'll see the TFL arise from this fibrillar structure more superficial to the vastus lateralis here, and we see it ballooning out. This is the TFL, and then it tapers and blends into our iliotibial band here. And then this is our long axis evaluation of it inserting into the ASIS with an example of our probe placement to the right, or sorry, to the left. But we do not appreciate any cortical irregularity or presence of anechoic clefts to be suggestive of a tear. So our overall impression is that this is a normal appearing muscle and tendinous echotexture without evidence of cortical irregularity. So now we'll move on to the anterior hip portion. Given that our patient had a cam deformity and status post arthroscopy 4 years ago, we did include this in our scan. Again, on the left, we'll see our probe orientation. We're going to be long axis to the femoral head neck junction, and our relative structures are labeled to the right. The labrum is going to be a fibrocartilaginous structure sitting just inferior to the acetabulum here. And then our femoral head neck junction is here, and it'll blend down to the femoral neck. And our joint capsule is going to traverse over the femoral head and attach onto the intertrochanteric line more distally here. And in our patient, this is the same orientation, but we wanted to evaluate for presence of effusion, or if you wanted to evaluate for any flap tears that could be present within our labrum, you can do a dynamic evaluation by passively internally and externally rotating the femur, and which is what we did here. We don't see any obvious effusion occur or any labral pathology, but we can appreciate a little bit of cortical irregularity here at the head neck junction. I play it again. It's very, very subtle, but around here is our cortical irregularity. So our impression here is that there was mild cortical irregularity at the head neck junction, but no evidence of fusion or a labral cyst. It is important to note that if you wanted to do more of a superior labral evaluation, you can do so by switching the transducer to a linear probe with higher frequency and scanning from anterior to posterior along the aspect of the acetabulum, which would be in about this direction, to further delineate its course and its echotexture and the posterior aspect of the thigh. But we deferred for our patient's anterior thigh pain. So now we did evaluate the iliopsoas within the anterior hip as well, giving its insertion into the lesser trochanter. So this is the orientation in short axis to the tendon and superior to the femoral acetabular joint, with the psoas tendon located medially and deep to the ASIS. So our tendon is here, with the iliacus making up most of the muscle bulk here, and the psoas muscle will be more medial here. And you can follow this in short axis as it traverses over the femoral head onto the attachment to the lesser trochanter. But we did turn at this location in long axis to evaluate how it looks going over the femoral neck here and with the iliopsoas muscle above. And the iliopsoas can also be traced long axis to its attachment to the lesser trochanter, and it's better to do so if we use a curvilinear probe to better appreciate it as it dives deep until to its attachment to the lesser troch, which we can see here. So the iliopsoas overall demonstrated normal muscular tendinous echotexture in our athlete without anechoic clefts to indicate presence of tears or presence of bursitis. So now to make this a complete scan, we'll look at the femoral nerve, artery, and vein, which these structures can be found more medially to the femoral acetabular joint. And again, we're looking at these in short axis. And as we can see, the femoral nerve is going to sit more laterally and the femoral vein is going to be sitting more medially. You can also look at this with Doppler, but we did not include an image of this, but it did indicate that it had typical vascular flow. And the femoral nerve did appear normal in this patient. So our diagnosis or our evaluation of this showed that it had normal caliber and flow with typical echotexture of the femoral nerve. So to go over our ultrasound report here, this is just the introduction, and we indicate that this was a complete anterior hip and thigh evaluation for anterior hip pain using a 10:1 megahertz curvilinear and an 8 to 5 megahertz linear transducer to complete the evaluation. And here's a summarization of the ultrasound findings we've included, which are all the findings that we previously mentioned throughout our presentation this morning. Again, more of these findings. So our final impression is that we diagnosed our athlete with a right-sided grade 2B rectus femoris muscle injury according to the British Athletics Muscle Injury Classification, involving a partial disruption of the posterior fibers of the central tendon. There was also cortical irregularity at the femoral head neck junction that's consistent with the patient's known CAM osteoplasty. So we did see this patient in follow-up 6 months later, and while he had recovered several months ago, we did reevaluate the rectus femoris lesion for academic purposes. And then here we can appreciate his video scanning from proximal to distal. Our rec fem is right here in the middle. And as we see the central tendon, we do not appreciate the anechoic lesion that was previously there. And then this is a still shot. Left is going to be his initial presentation. On the right shows resolution of the anechoic lesion. And here's our references, and we want to thank you for your attention today. If you would like to learn more about this topic, as we discussed earlier, we encourage you to follow this link to listen to Dr. Balowitz, Dr. Bacall, and Dr. Davis give excellent presentations on further details regarding the rectus femoris injuries. And again, Eric and I want to thank you for your time today, and we're happy to answer any questions you might have.
Awesome. Well, thank you so much, Sharnée and Eric. That was a very thorough and detailed presentation with some really great images. I think this case was, still important and helpful, I think, to bring up for rectus femoris, injuries and quadriceps strains, just for the fact that, you guys did a really good job, I think, of highlighting, emphasizing the anterior thigh, protocol for these scans. Because we classically think, that these can either, occur at the anterior hip or the anterior knee, but a lot of the majority of these are going to actually be occurring in the thigh region, and that kind of becomes that no man's land. And trying to figure out a good set protocol, for that area is important, so you don't miss out. Because you guys had mentioned, there are going to be other, muscles in that region outside of the quadriceps, Sartorius, TFL. Especially with contusion, type injuries that can get injured. So important to just kind of still have a set protocol when you get down to that area, as you guys had highlighted. Just a couple other just quick points, that had been kind of mentioned in some of the other, rectus talks as well too, is just, the anatomy for the rectus femoris is really that central or indirect head, goes really down, far distally as you guys had measured. And so, just being aware, how far those injuries can occur. And as you had mentioned, important to kind of measure that distance as well too, because it can be important for prognosis. And then just really going down to, as you guys had in your report, you guys had the, specific findings of the injury on the ultrasound, but then having a classification system. And so that VAMIT classification system has really, now started to be the tried and true for going back to describing these injuries, and it can be helpful for everyone to kind of have that same, terminology to kind of understand these injuries. So important that you guys kind of highlighted, I think, that in the report. So those are just a couple of the quick comments that I had, but otherwise I'll kind of open it up for any other, questions or comments from anyone else.
Thank you.
Yeah, this is Doug Hoffman. Great presentation. Very organized. I like your protocol. I mean, it was very methodical, hit each muscle, went back to the hip, which makes sense to me because we're going to scan each muscle from proximal to distal. If it's more of a distal injury, maybe I'll switch over to the knee as the joint. But again, you're starting at the hip, which is logical because, again, you want to assess the full length of the muscle. And really what you did is what I do is a short axis survey and then go long axis if you see pathology.
Mm-hmm.
And again, a very nice review of the anatomy, just a couple esoteric anatomic details.
Mm-hmm.
There is fair amount of variability in the quadricep muscles going into the quad tendon. So they described 3 layers, but there can be 6 layers, there can be 2 layers. So just be aware of that variability and not confuse that as potential tear or a quad tendon injury. And then the other anatomic detail is this muscle tendon unit called the tensor of the vastus intermedialis. And I think I saw that as you were doing and it's between the vastus intermedialis and the vastus lateralis. And it's a very thin muscle often, and then a very long, thin tendon. And the only reason why I mention it, if you're seeing a fair amount of quad injuries, oftentimes you're scrutinizing the aponeurosis between the muscles. So in this case, again, it would be the vastus lateralis and vastus intermedialis. And we often look for little gaps. So, and in this case, the gap would be normal because it is actually the tensor of the vastus intermedialis. And so if you do a lot of quadricep work, it's worth reviewing that because I think I saw it on yours. It was quick, but it's worth knowing that. One thing on the report that we've never talked about before, and I throw it out because there's variability, and I've talked to my radiology colleagues about this, and you mentioned the cam lesion, and I would have mentioned that too, and I don't know if I would have done anything different. But what I do sometimes is I find that particularly these, other findings that we have, oftentimes in my report, what I'll do at the beginning of my report was say correlation is made with a radiograph so-and-so date. And we've talked about reviewing radiographs before we start a scan. And at the end of the report, I tend to say, the finding of cortical irregularities or, concavity at the head neck junction correlated with the radiographs is consistent with the cam lesion. And some radiologists say, well, no, we shouldn't bring in other imaging studies because it should stand on its own. I'm on the camp that we should bring in other imaging studies like a radiograph and say, correlated with those radiographs. Or in this case, if this patient had not had a radiograph of the hip, I might say something like, suggestive of a cam lesion, consider plain radiographs based on clinical concerns or something. Just a topic of discussion when talking about the report. I wasn't going to mention this, but you did show a follow-up. I think there's more utilization for ultrasound and following these patients over time and providing some objective evidence of healing. We typically treat these patients clinically, but there is some evidence that shows that the presence and then the resolution of vascularity, meaning the scarring, as well as the coordinated muscle contraction with dynamic images, the resolution of those along with the clinical course can be helpful, particularly if people are not symptomatic and then they want to get back. And we have objective evidence to say, no, you're not quite ready to get back. We still see an immature scar, et cetera. Again, a different topic, but I just mentioned that. Brennan, you mentioned a degloving injury. Did you want to comment on that? Is Brennan on?
Yeah, I'm here, Doug. Yeah, thanks.
Okay.
Yeah, so I think one of the injury patterns that I've seen a couple of times in the rec fem is this degloving sort of injury. And it's been described, I don't know, Doug or Stephen, if you guys have seen this, or Ryan, but it's been described a little bit on MRI and, primarily in like kicking athletes, right? So people who have that hip extended, knee flexed, and then kind of that forceful motion with it. And essentially the tendon more or less like tears out from inside the muscle, essentially. And it kind of happens about like mid to distal junction, maybe more mid, in the thigh. And it's a little bit of an interesting, injury pattern. You see kind of this halo of fluid around, like completely circumferential around the tendon, with kind of this surrounding muscle edema pattern, or maybe a little bit of a muscle injury pattern with that. And I think those are, certainly maybe a different type of injury. And I've only seen, a couple of them. There's only a couple of like MRI reports on these kind of this injury pattern. I don't know if anyone else has experienced these, but I don't know. I've seen them be a little bit more problematic down the road than kind of the standard muscle injury. I don't know, Doug, have you seen these?
I haven't seen them in the rectus, and that's what I was going to ask you. It would seem like the healing time would be longer compared to the typical sort of mid-substance muscle injury pattern.
That's been my experience, but I've only seen a couple of them. Yeah, I don't know. There's just a few MRI, reports that I've seen.
Yeah, Brian. Yeah, I've just seen just the case reports and everything describing those injuries. I think the key is then it doesn't really then truly like involve the actual central tendon fibers. It just really actually is the involvement around the muscle within that kind of muscle area. But I think then the case reports that I've seen is that, yeah, those are usually going to be longer injuries for recovery, just because they are pretty lengthy, you know, injuries as well too, where they occur.
There was
How long did it?
oh
I'm sorry, go ahead.
yeah, just a quick comment in the references. I believe the author's name is Kasarjian, who does a fair amount of MRI work on these rectus femoris injuries. And just as you were saying, Brennan, he does describe these in some detail. And so just for the audience, if they need a reference, and I know Dr. Bailowitz talks about some of the degloving mechanism as well in his talk.
How long did this patient need to recover and get back to kicking? I know you got to follow up at 6 months. Was it that long, or was he able to get back sooner?
He was actually able to return a couple weeks. I think it was like 2 to 3 weeks later. He was back to full playing.
Oh,
We did attempt to aspirate some of the fluid collection, but we weren't able to pull any out. And he was able to just kind of modifying activity. We did also do a intramuscular PRP injection, which he felt like helped. Not exactly sure on the timing of it, how much of an impact that played, but he was able to get back pretty quick and back to starting.
He was when we saw him, Eric, he was 4 or 5 weeks from the initial injury?
Yeah, I think it was about 2 months.
2 months, okay.
So I think at the measurement, there's some literature that supports that with that measurement, we would expect somewhere between like 60 to 80 days of return to sport. And so really we saw him at about, I think 56 days from his injury or something like that. And so he kind of got better in like that expected time range based on the size of the lesion. And so that might also have played a role of just time. And he also actually took some more time off than the time he was taking off during training camp as well.
All right, well, perfect. That was a great discussion. Unless anyone else has any other, you know, points to make. Otherwise, Sharnée and Eric really appreciate the presentation here. I hope everyone has a good Memorial Day weekend. We'll be meeting again in 2 weeks, and one of the fellows, Dr. James Gardner, will be giving the presentation at that time. So thanks again.
Thank you. Have a
Thank
good
you.
one.